Good morning. Our lecture today named Appropriate Use of Blood. فاطمة عبد الوهاب, lecturer of Clinical and Chemical Pathology, Australia. A blood component are a constituent of blood separated from whole blood, such as packed RBCs, plasma, platelet, cryoprecipitate, derived from the whole blood. By having a whole blood product and a blood product, such as our blood components, such as a packed RBCs, plasma, fresh frozen plasma, platelet concentrate, factor concentrate, or cryoprecipitate. Some other products called plasma derivatives, such as plasma proteins, albumin, coagulation factor, immunoglobulins. Now we have a mass program in Egypt for plasma fractionation and plasma donation. It should be raised in consideration. This is a nice diagram called what can I do from a whole blood product. The whole blood bag, I can have a packed RBCs and a fresh frozen plasma. Then I can, from this fresh frozen plasma, prepare a cryoprecipitate and a cryodepleted plasma, or some sort of causes called a cryosupernatant. That's a real picture. Also, I had I have downloaded from the net, but it's a real. Anyone had entered the blood bank, you can see the whole blood donation bag. From this blood bag, I can have a satellite bag. I have 3 bags or double bags attached to the main blood bag. These bags I separate from the whole bag, the packed RBCs in one, the cryoprecipitate in one, the cryosupernatant in one, or if I don't want to prepare cryo, I separate the packed RBCs and the fresh frozen plasma. The whole blood bag, almost 450 milli, containing an anticoagulant. Hemoglobin, usually the same of the human normal hemoglobin, 12. The hematocrit, reaching the normal level of hematocrit in blood. Non-functioning platelet, as a platelet is a very short-lived in should be for 5 days, but the whole blood bag can be maintained for about 1 month. So it's non-functional platelet, non-functional Levi factors, it's a coagulation factor. When I'm preparing fresh frozen plasma, it should be within 4 to 6 hours from the donation to have an efficient plasma and then frozen immediately. So the whole blood bag, if it is not fresh, what meant by fresh? Fresh at the same time of donation, I can use as some cases of cardiothoracic surgeries or hepatic transplantation, or etc, etc, etc. When I have stored a whole blood bag, I should have a non-functioning platelet and a non-functioning coagulation factor, so could raise for the importance of packed RBCs separation and immediate freezing of plasma. Here is the storing condition of blood. It should be in fridge, blood bank, specialized fridge, temperature monitored regularly during the storage. Transfusion should not delay for more than 30 minutes from issuing from the blood bank and should enter within 4 hours of issue. As we mentioned before, the whole blood, if stored, had a non-functional platelet and non-functional coagulation factor. So the main indication of the oxygen carrying capacity, usually for wide use in hypovolemic shock and in exchange transfusion of neonates. And exchange transfusion in neonate also, it can be needed as a fresh donation in some cardiothoracic surgery for priming of the cardiothoracic machine. I have some contraindication to whole blood. If my patient needs only to correct the anemia, they no need to have an extra 200 milli of the plasma. I I need the blood for correction of anemia. So I don't give whole blood for correction of anemia. I give back the RBCs. This volume overload can harm the elderly patient or the patient of cardiac comorbidities. So it's contraindicated for anemia. It's widely used as a treatment for hemorrhagic shock, and we mentioned before in exchange transfusion, or donated freshly in some major surgery. We should respect the APO and RH in typing, the routine typing in all blood banks. We should do the APO and RH. I cannot issue an incompatible blood. Here we should insist that I will never give any medication in the same IV line with blood. Any medications. I should have a separate line for blood, a separate line if my patient having an IV drugs or IV solution. The blood not compatible to be administered with any drugs. Completion of transfusion within 4 hours. In the first slide, the packed RBCs are the most dense component of blood. If I centrifuge my blood donated back, I will see this figure. I will see it's a real picture downloads from the net. This resembling the order seen in any centrifugated blood sample. I can see the packed red cells, a very small line of buffy coat and the plasma. So if my patient don't need the plasma, for example, given for correction of the anemia, I don't need to transfuse a whole blood, and then I will, as a whole blood preservation in the fridge will destroy the coagulation factor. So I then divide the whole blood bag to packed RBCs and plasma. After centrifugation, the bag held in a cell separator like the other picture on the right. Then by squeezing the bag, the plasma are out of the bag to the satellite for the second bag. Here are the characteristics of the packed RBCs. It's lesser in volume, but it has a higher hemoglobin concentration as it is concentrated. Normally, we have 12 grams per deciliter. The donated blood was the primary bag was about 400 milliliter. In 12 by 4 equal 42. The packed RBCs could have a 45 gram in the whole bag. Whole bag RBCs 45 gram. This 45 gram, when transfused to a normal or a deficient or anemic population, it should raise the whole blood hemoglobin by around 1 gram, as we have almost 4 to 5 liters of blood in our bodies. By scissoring, you can conclude that each bag will raise the hemoglobin by 1 gram. Each bag of concentrated RBCs should elevate the hemoglobin. Also, it elevates the hematocrit. For quality control products of the packed RBCs, no more, the hematocrit should not be more than 80%. At more than this, it will be a more visit for transfusion. Here we can see we can correct anemia that need transfusion by packed RBCs in almost aplastic anemia, anemia of oncology, anemia of chronic disease, anemia in renal patient, and in acute blood loss, I can use the packed RBCs. If I don't have a coagulopathy, the packed RBCs, I can increase the oxygen carrying capacity and can increase. I can then replace the plasma by crystalloid or colloid in acute hemorrhage. So in the same indication, the backed RBCs I can use in acute blood loss also as whole blood, but have the advantage of that I can correct the anemia by lower transfusion volume, less risk for circulatory overload. From blood also I can separate platelets. I can separate platelets either from each blood bag. I can separate the buffy coat containing platelet, or I can prepare platelet by apheresis. What's apheresis? Apheresis is a separation of blood product, or a separation of any cellular component of blood. The apheresis machine, like the dialysis machine. It's not the same mechanism, but it's the same. Like I have an outlet of blood. This blood is centrifugated outside the body. I then return all blood to the donor again, but I having a special filter that I select platelet for apheresis. These platelet apheresis are more concentrated, less contaminated by red cells, are filtered as during preparation. I filter after centrifugation and preparation of the buffy coat and collection of platelet, it passes through filters. So I am having the advantage of being more concentrated, less RBCs contaminated, and less leukocyte contamination. It can increase the blood platelet in thrombocytopenic patient for about 1,000 in one platelet concentrate prepared from apheresis. It's called single donor platelet. But what if I don't have an apheresis? I should prepare the platelet dose from different blood concentrates. The therapeutic dose, or the dose needed for transfusion in thrombocytopenic patient, it should prepare from 6 different donors, which is called random donor platelet. Here from the definition you can see it's more antigen exposure, more donated component are from 6 different persons, so the more risk of transmitting infection. From preparation I prepare using a special expressor like the backed RBCs, so I may have a contamination of white blood cells and platelet. So the white blood cells and platelet, more antigen exposure, and then more resistant to treatment elsewhere, as we will mention before. It's called platelet refractoriness. The storage of platelet, unlike the blood, platelet only kept for 5 days. It should be in room temperature, never to cold refrigerate or freeze. It has some indication. That's thrombocytopenia and platelet dysfunction or antiplatelet drugs overdose. Also, I use platelets in DIC and in massive blood transfusion. Contraindicated in TTP. Never I give platelet in a thrombocytopenic due to thrombocytopenia. TTP, it's never I transfuse platelet, even if it's thrombocytopenic. Then contraindicate, I don't give platelet prophylactically. Here is the dose, how to I measure platelet, or how I calculate the dose I need in platelet. This is the other dose maintained by apheresis unit, or the random donor platelet from 6 donors. It should do the platelet increment. What meant the increment? The increase, yeah. The increase of platelet should be to 20 to 40,000. Either I use 1,000 per liter, or 10 to the power 9 1,000 microliter, or 10 to the power 9 in liter. Not to confuse you. Either I use 20,000, 40,000 per cubic microliter, or I use 20 to 40 times 10 to the power 9 per liter. It's a mathematical problem, no way. The increment should be can be lowered if the patient in DIC or it have an splenomegaly to sequester the platelet, or in sepsemia and fever. This slide demonstrates the platelet concentrate collected by apheresis, that the component had a minimum 3 times 10 to the power 11 platelets. One platelet apheresis should increase the adult patient count as described below. About the fresh frozen plasma that separated from the whole blood component within the 4 to 6 hours through centrifugation contain the all normal coagulation factor, should be rapidly frozen to -25 or cooler. This slide demonstrates the indication of fresh frozen plasma infusion. The cryoprecipitate, one of the blood components that prepared from fresh frozen plasma through overnight thawing in the fridge, then centrifugation and resuspend the precipitate in 10 to 20 milli of plasma. This slide demonstrates the component content of the cryoprecipitate. This slide resume of the what modification can be done on the blood component. Irradiation. Irradiated component exposure to irradiation make inactivation of the lymphocyte, prevention of GVHD or other immune-related complication. Irradiation should be done in any recipient with suppressed immunity, patient with chemotherapy, neonates, extremities of age, intrauterine transfusion, etc., etc. Volume reduction can be done for aliquoting in pediatric units, washing for some cases with allergic conditions, filtration, and so. Regarding leucodepletion of the blood component, what's meant by leucodepletion? Removal of leukocytes from the blood component, hence through filtration. Some definitions include that leukocytes within the component should be less than 0.5 times 10 to the power 6 per unit. What the disadvantage of leukocytes? Disadvantage of leukocytes includes the transfusion reaction, the non-hemolytic transfusion reaction, and hindering the alloimmunization. What meant by alloimmunization? That my recipient recognize the donor leukocytes and contains subsequent immune response against them, making difficulties in platelet transfusion or in patients that will receive transplantation, and so on. Regarding the indication of leukodepletion or filtration of blood products that we mentioned before, these are the main causes of indication for blood product filtration. Regarding filtration and or leukodepletion can be done either pre-storage, before storage of the blood component. It's stored as filtered. Any product prepared by apheresis had a pre-storage filtration. Pre-storage filtration renders the donated blood bag as a closed system, so having the advantage of being retaining the viability and retaining the variability of the bag till the end of the expiry. No storage lesion can occur. Filtration of blood bags or blood component, almost the only disadvantage here is the cost and the well-trained personnel needs. So the filtered blood should be orderly done for indicated person only due to the cost of pre-filtration, pre-storage filtration. Sometimes I can filter the bag when I need just pre-transfusion or bedside. Definitely it will reduce the cost, as I will do for only needed patient or only pre-transfusion. But it has the limitations that I can only filter the newly donored blood bag within 3 days. What about RBCs wash? I can need to wash the RBCs. What's the meaning of wash? The meaning of wash is that I replace the plasma in the RBCs bag by physiological normal saline. Why I am in need? If my patient is in need for transfusion and he has a history of severe allergic side effect after transfusion. So it's maybe fatal allergic reaction, especially in some cases with IgA deficient patients. Wash also can remove some storage pool storage lesion in the RBCs bag. What meant by storage lesion? That the storage stored blood can have some mediator, have some increase in in potassium, decreased in 2-3 dBg, increase metabolites that I don't need in the blood bag. Filtration, washing also aim to reduce this mediators from the blood bag. Also, it can help in white blood cell removal, but not the standard. The standard, if I need a leucodepleted blood, I go through filtration. The irradiation inactivate the white blood cells. What's the harm of these inactivated white blood cells, especially lymphocytes, not the neutrophils? Lymphocyte inactivation. The donated component has an immunocompetent lymphocyte that can attack the recipient body. In a syndrome post, graft versus host, it is the opposite of rejection. In rejection, the recipient body refuse or reject the transplanted or the grafted tissue. But here, the blood act as a graft, and the lymphocytes in this graft attack the donor body. Inactivation occurs by irradiation of the product. Inactivation is essential in immunocompromised blood product recipient. What are examples? Examples are the patient on chemotherapy, the transplantation patient as they receive immunosuppressive drugs, immunodeficient patient, either congenital or acquired, intracranial transfusion and exchange transfusion. I can irradiate the backed RBCs, the whole blood, the platelet. No need for irradiation for plasma or cryoprecipitate, as the cellular component almost is decompensated by freezing. Next in our lecture, we will go through the complication of blood transfusion. I have two types of complications: the acute or immediate complication and delayed complication. Within each category, the complication or the adverse reaction can be immune mediated or non-immune mediated. We will go through each through the lecture. This diagram illustrates what if I suspect an adverse reaction from the blood transfusion. Here is some symptom and sign, and which and there is a complication can be attributed to each sign. After we will illustrate the different complications, this slide will be easy, inshallah. The most serious and the most important to exclude is the acute hemolytic transfusion reaction. that occur when I have transfused a mismatched blood product, mainly RBCs. If I transfuse an incompatible blood, the recipient will have antibody against the transfused RBCs. These antibody are complement fixing, causing intravascular hemolysis, may be reached to acute intravascular hemolysis, acute hemoglobinuria, acute renal failure. In severe cases, patient will die from shock and the IC. So I should rule out the acute hemolytic transfusion reaction after any adverse sign occurred after transfusion. By proper cross-match order before transfusion, I can prevent the acute hemolytic non-transfusion reaction, but also some clerical error, sample mix, or anything before the issuing or after the issuing of blood can lead to. So I should exclude. It's rarely that you can face in real life, but you should exclude after each adverse effect noted in the after transfusion in the recipient. Here are symptoms and signs. Here is the needed labs for confirmation. Acute lung injury, transfusion-related acute lung injury, TRALI, one of the most fatal complications after blood product transfusion, if this blood product containing anti-HLA or anti-neutrophil antibody. It occurs either as a two event pathway or one event pathway. Whatever the cause, the net result is acute pulmonary distress after transfusion. In real cases that are faced in life, we can face cases of TRALI. TRALI should be also ruled out after transfusion with followed by respiratory stress. It may have very high mortality rate. So I prevent the multiparous hormone from donating plasma containing product. I can the problem also in plasma transfusion or in blood transfusion from multiparous women. Why multiparous? As the multiparous female having a very high risk of containing anti-HLA and anti-neutrophil antibodies. From each fetal-maternal hemorrhage, these fetal-maternal blood contamination during each delivery, there is a risk for antibody production against the foreign fetal antigens. So by repeated deliveries, this female or this woman containing multiple antibodies in their plasma product. Another complication called transfusion-associated circulatory overload. Usually in old age with cardiac comorbidities after we transfuse a blood product like the RBCs or plasma or etc. This product containing high oncotic pressure increase the plasma cell volume, causing a heart failure or circulatory overload. Clinically, I can differentiate, but both having a pulmonary or respiratory distress after transfusion, both have met in real life. There is a comparison between them. The delayed transfusion reaction occur mainly more common than the acute transfusion reaction, caused by a non-complement fixing antibody or incomplete activation of the complement system. So the RBCs are coated with either IgG or complement. The hemolysis occur in extravascular, example given spleen, start 1 or 2 weeks after transfusion by amnestic response or immune response against the transfused product. It can elicit immune response, but non-complement fixing antibody and non-ABO blood group antibodies. Different antibodies may be non-specific, sometimes causing or called amnestic reaction. This amnestic reaction, I should suspect that my case had an delayed hemolytic transfusion reaction by this history of transfusion. Then after 1 or 2 weeks, falling in hemoglobin, increasing in bilirubin, LDH, no hemoglobinuria, no hemosideриnuria, the direct antiglobulin test may be negative or sometimes weak positive. The antibodies start to rise after, as we call, 1 or 2 weeks. Here we can demonstrate the GVHD as one of the delayed complications after blood product transfusion. That we mentioned before, the need for irradiation is to prevent GVHD. Here we go through this slide and the next slide through the graft versus host disease caused by blood transfusion. Post-transfusion purpura, one of the delayed complications after blood component transfusion, mainly platelet transfusion or white blood or red blood cells. There is an immune response caused by antiplatelet antibody, maybe severe bleeding, should be suspected in cases with severe thrombocytopenia followed transfusion of RBCs or platelet components. In real life, we can face the transfusion associated iron overload. It's inevitable, except if we do iron chelation therapy for regularly transfused patients. The iron have no excretion mechanism from the body. Even in hemolytic patient, this patient or chronic hemolytic anemia or acute hemolysis, there is no loss of iron. The iron is liberated in the tissues. Macrophages can cause secondary hemochromatosis that affect liver, affect heart, affect skin, affect pancreas. So in multi-transfused, multi-red blood cell transfused persons, such as persons with chronic anemias, hereditary conditions, hereditary anemias, etc., 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 these patients should receive iron chelation therapy. As we mentioned before, we use ABO blood system for routine typing of the blood product, but we have also different engines that can use for grouping. The most common is the APO, the most dangerous is the APO. Still, we have some rare engines or rare subgroups. In chronic transfused patient or in multi-transfused patient, by different engine exposure, he or she or the recipient develop antibodies against the defective antigen that he has. If we face a recurrent mismatch, my patient need to transfuse blood, I can find a compatible blood. It's an APO compatible blood. If I'm doing cross match, I can find this product cannot match the recipient. Cross match done in vitro before issuing of blood, I cannot find a matched blood for a regularly transfused patient. I go through detailed typing of the RBCs and the management by finding appropriate antigen matched format. Massive blood transfusion. Massive blood transfusion is a condition termed when I transfuse a huge amount of blood within short period of time, it has a certain definition that if I transfuse more than 10 packed RBCs or 4 units of RBCs in 1 hour or more than 50% of total body volume within 3 hours. Total blood volume, sorry, not total blood volume. There are some differences in the definition of massive blood transfusion in adult than pediatric. Here is the definition of pediatric: that I transfuse 100% of total blood volume within 24 hours, or I transfuse more than 10% of total blood volume in minutes, or a replacement for more than 50% of total blood volume by product within 3 hours. There is a definition that we should stack when I define a massive blood transfusion here, having a certain pathophysiology, that there is a loss of coagulation factor and platelet. As when I transfuse a bag red blood cell, it's not containing platelet or coagulation factor. There is a consumption of procoagulant material, dilution of coagulation factor. There is the condition in which causing tissue hypoperfusion and hypovolemic shock. Massive blood transfusion we need in major surgery or major trauma, and there is a mechanism by which tissue hypoperfusion occurs simultaneously. Here is detailed steps how we overcome a massive transfusion protocol associated tissue hypoperfusion. I should transfuse blood, plasma and platelet in a ratio 1 to 1 to 1, especially when I'm expecting that severe blood loss will occur. Then I should correct the fibrinogen. I should give an antifibrinolytic. I should reverse any other coagulation defect. I should be care of calcium, as calcium is very important in the coagulation factor, but also can occur systemic manifestations such as tetany and. The calcium is chelated through citrate, that is the anticoagulant material in all blood products. So from massive transfusion, the calcium deficient will be inevitable. So I must be care of calcium. It can cause arrhythmias or some other complication in hypocalcemia. I should avoid the acidosis associated with recurrent transfusion, as the stored blood having more potassium and more mediators and more tendency to do metabolic acidosis. I should avoid the hyperthermia that causing tissue hypoperfusion. I should be care of the hemodynamic instability through the blood pressure. I should control the source of bleeding. The term of autologous blood transfusion had increased in recent years. That I make my patient that he need an elective surgery, donate a blood for him to be used if we need it in surgery. This avoids the mismatch complication, avoids the complication of finding a suitable donor, avoids the complication of transmission of infection, but this product cannot be used for except for only for this patient. If I didn't do a detailed virology screening, etc., etc., etc. But it's the safest for that I do for myself, the safest for regarding transmission of infection or occurring of complication. But should be considered that some of patients undergoing surgery cannot donate blood for themselves, cause of anemia, cause of comorbidities, cause of age, etc., etc. Sometimes it is done by another mechanism that called acute normovolemic hemodilution, that immediately before surgery I pick up blood from the donor, the patient, then I replace the fluid by crystalloids or some sort like, and if I need blood, in the surgery I go through the blood taken immediately before the surgery. Here, this slide shows the transfusion transmitted infection. Transfusion transmitted infection, either bacterial or viral. Within the bacteria, the most common bacterial contaminated products are the platelet, as they do not refrigerated. It is stored in the shelf in room temperature around 25 to 25 on agitation. So the bacterial contamination occur mainly in platelet product. Other bacteria that that grow in low temperature can occur also in blood component, but it's rare, but it's found. So a bacterial contamination, it's a febrile complication, immediately occur post-transfusion. I should discriminate from the acute transfusion hemolytic reaction, and I should discriminate between the other immune causes of adverse reaction. Other contamination in blood products should be screened in the syphilis, malaria and prion. In Egypt, we don't test them routinely, the malaria and prion, but syphilis in each blood bank in Egypt, syphilis is routinely tested. The viral that can be transmitted through blood transfusion are the HIV, HBV, HCV, also CMV, Epstein-Barr, and human parvovirus B19, human T-cell lymphotropic virus. In Egypt, routinely we are tested for the HIV antigen antibody and HBs antigen and HCV antibody. Proper questionnaire for donation, that I should escalate any donor with a minor surgery or a minor procedure intervention that could have a risk of infection. I defer for time interval. It depends on the procedure done. Proper history and proper screening through chemiluminescence or ELISA for HBs antigen, HIV, and HCV and syphilis are routinely tested in blood bank.